Welcome to Penetrating Thoracic Trauma. Time matters. I'll be your host as we explore why time is so important in penetrating thoracic trauma. At the end of this lesson, you should be able to discuss the prevalence and pathological consequences of penetrating injuries, discuss the types and pathology of different life-threatening penetrating injuries, identify important elements of the scene size-up associated with penetrating trauma, special assessment, treatment, and transportation consideration for patients with penetrating trauma, identify and discuss the goals for increasing survivability, and explain the EMS provider's role in improving the assessment and management of penetrating thoracic trauma. Let's look at a patient with this type of injury.
Hey, what happened?
That fool shot me.
What's your name?
Matt.
Diego, let's get some oxygen, please.
This patient is becoming hypoxic because of his shallow ventilations. Luckily, this paramedic has recognized the need for supplemental O2, and most paramedics do a reasonable job identifying and correcting this problem. Unfortunately, they forget the importance of the other two areas of concern. Circulation is just as important. Oxygen and CO2 have to be moved to have any effect. Most trauma patients are bleeding somewhere, and with penetrating thoracic trauma, the consequences of undetected bleeding can be rapidly fatal. Also, the loss of blood volume leads to fewer red blood cells to transport oxygen, hypoxemia, and decreased perfusion, decreased movement of oxygen and CO2. Eventually, if the medics don't rapidly recognize the hemorrhage, myocardial failure will result. Deadly penetrating injuries include lung tissue trauma, hemo and pneumothorax, cardiac and great vessel and esophageal injuries. Paramedics often think of pneumos when they consider thoracic trauma, but what about pulmonary lacerations or pulmonary contusions? Both types of injuries interfere with the movement of oxygen to the alveolar sacs for transport to the red blood cells. The bleeding associated with pulmonary lacerations may also lead to hypovolemia and pneumothoraces. Pulmonary contusions may lead to ARDS, adult respiratory distress syndrome, pneumonia, or pulmonary edema. On a chaotic trauma call, these may not seem important, but they will ultimately be very important to our patient's survival. The medics will have to rule out pneumothorax, or even worse, a hemothorax. These conditions are often recognized by paramedics, but too often we jump to the conclusion that a needle decompression will solve the problem. Remember, a needle decompression should only be used if a tension pneumothorax is present. I'll always tell my students that if a patient complains that you're about to stick a needle in their chest, they have too much oxygen and the needle is not needed.
I'm going to reassess you really quick, but we might have to put a needle in your chest to expel that air.
No.
No? Let me check your site.
We often focus on lung injuries and chest trauma. Remember, the heart, great vessels, and esophagus are also in the thorax. Severe bleeding is always a concern. Cardiac tamponade can result from penetrating chest trauma. Blood could be leaking into the pericardial sac and slowly compressing the superior and inferior vena cava, ultimately leading to myocardial failure. Remember Beck's triad. Hypotension, JVD, and muffled heart tones usually indicate this condition. You can also check for pulsus paradoxus, a drop in blood pressure more than 10 millimeters of mercury. Check a distal pulse during a deep inspiration and the pulse will disappear or diminish. The pathology of most penetrating injuries involve bleeding and hypoxia, but EMS providers often overlook the developing acidosis and hypothermia. Acidosis will interfere with any oxygenation efforts, and in an acidic environment limits the ability of oxygen to bind with hemoglobin, worsening hypoxemia. With the loss of blood and the decreased perfusion, trauma patients rapidly become hypothermic, and this prevents proper clotting and will exacerbate bleeding. Hypothermia is not good for trauma patients. Keep them warm. Scene safety and situational awareness should always be the #1 priority in any trauma situation. Index of suspicion should be based on the type of penetrating trauma, low versus high velocity, type and size of object, and anatomical location of the wound.
Now, Matt, do you know of any medical problems that you have? Are you allergic to any medications?
A patient's health and medical history should be considered because this may affect compensatory mechanisms. Your initial primary assessment should include assessing airway, breathing, ventilation, pulse check and hemorrhage control, communicating with your patient and checking level of consciousness, and exposing the patient to visualize any injuries. This should not be a linear process, but dynamic and fluid. After the initial assessment, perform a rapid head-to-toe, determining life threats and only intervening as necessary. Rapidly package and transport your patient. The patient assessment should be a dynamic process. You won't know if your patient is deteriorating if you don't check.
Now I'm just going to take a look at this site. Let me know if you notice any relief.
Talking to your patient is the best and quickest method to reassess your patient. One of the first things that changes in the patient's LOC as the brain becomes hypoxic. How many times have you heard 10 minutes or less, the golden hour, platinum 10? You may have a local protocol dictating your off-scene goal. We should not really be focusing on an exact time, but on what is important for patient care, and that is transport.
Diego, code 3, nearest trauma facility, please.
Yes, sir.
Time does matter, and the more we take on scene, the longer it takes to get the definitive care a patient truly needs. Our care matters, but only if they ultimately survive the process.
UC Davis Trauma Center, this is AMR 223.
Now, once you're en route, that means the ambulance is actually moving. Oxygen saturation should be 95% or greater, with an end-tidal CO2 between 35 and 40. And oxygen administration and ventilation should be supplied to accomplish these goals. A cardiac monitor and intubation should be considered in all patients with penetrating thoracic injuries. The use of large quantities of isotonic crystalloid solutions, normal saline, lactated ringers, in a bleeding trauma patient is controversial. Use common sense and follow your local protocol. If you cannot plug the hole, large amounts of fluid will most likely worsen your patient's outcomes. These fluids do not carry oxygen, and they are often not heated, leading to hypothermia and more bleeding. And always remember to keep your patient warm. That means turn off the air conditioning and cover your patient. Remember to reassess level of consciousness, your initial assessment, any complaints, and any interventions. Trauma patients can change in an instant.
UC Davis, UC Davis. This is Medic 223 in Reactive Facility, code 3, patient notification whenever you're ready.
Remember, the hospital can only be prepared if you notify them. Call in a report early so they have the opportunity to get the right people and equipment in place. They're part of our team. Definitive care for a trauma patient is hospital care. Paramedics and EMTs cannot stop internal bleeding, rapidly correct acidosis, or repair damaged tissue. Only a trauma surgeon or other medical specialist has the capability, and those individuals and their equipment are only found in hospitals, and even more specifically, trauma centers. The less time you're on scene, the quicker the patient receives definitive care and the better chance for survival. The type of call and your geographic location will determine what method of transportation you choose. But remember, flying someone is not always the fastest method. The easiest way to remember the pathology of trauma, it's not always about the airway. You have to remember breathing and circulation. Here's a quick way to think about what's going on. In, on, off, and out. You have to get the oxygen in. Then it has to pass from the lungs onto a red blood cell, and then be moved to the capillaries and get off at the cellular level. Finally, CO2 has to move from the cells to the lungs and out. Without adequate oxygenation, perfusion, and ventilations, one or all of these necessary but simply explained physiological requirements will not be met. Trauma patients may have problems with all of these. Rapid assessment and rapid transport are the top priorities. Recognize the limitations of IV fluids in an actively bleeding patient. Isotonic solutions do not carry oxygen or CO2, and they do not stop bleeding. Oxygen only works if there are red blood cells and pressure to transport it. Both are limited in hemorrhage and can worsen dramatically in a very short amount of time. Trauma centers can only save lives if they know you are coming. Notify early. They're part of our team. Penetrating thoracic trauma is a leading cause of trauma death and a significant contributor to trauma deaths. Early recognition, rapid assessments, and rapid transports are the key to increasing survivability. Airway is important, but so is breathing and circulation. Don't forget, trauma patients are bleeding to death. Time matters. Every second counts.